Thanks everyone for taking up this time to listen to my paper. I admit I was quite flattered when I was called up and like, hey, we like your paper. Could you say something about it? Probably because it's a serious issue when it comes to the practice of anesthesia in Africa. And not only because it addresses technical issues, but it addresses also more of human resource issues and training issues, as we will see when I will do the presentation of the paper. So I think I can go ahead and I'll just talk about the paper. Actually, I prefer to talk about it rather than do a PowerPoint presentation, because this paper was written in a background of a lot of frustration and a lot of hardship. Because when I finished my training as an anesthetic trainee in 2017, working in the major towns of Cameroon and even going for outreach sessions in the rural areas made me realize that there was really a problem to be addressed. And that problem was the difficulty with managing cases that require pediatric anesthesia. And the outcomes are really horrible, even before I went out to the field. And even right now, the outcomes are getting a little bit better because of this little training effort we're trying to put in place with the registrars we have and the little courses we do. But this paper was sort of was going to set the center stage for us to implement change from one way or the other. So diving into the paper, we based ourselves with the other co-authors who I would really like to quote here, because they're people who have really influenced my vision of pediatric anesthesia. You have Dr. Rebecca Gray, who's one of the senior pediatric anesthetists at Red Cross Hospital, who's I would say my mentor, my mom in anesthesia. And she sort of directed that energy I had to like do something about the difficulties we face in our setting, which is like the low and middle income country setting. And then we had like a third person, Dr. Faye Evans, who is also a pediatric anesthetist practicing in the US, who gave the perspective from a high-income country perspective, and sort of directed the paper to really appeal to people who are in high-income settings to better understand the situations, the difficulties we face. So for a start, in introductory phases, we sort of came up with what are the standards. You have the WHO standards, which are prescribed by the World Health Organization, and you have the General Initiative for Children's Surgery, the GIGS initiative, which you may have heard about, which has done a lot of work to sort of orient the practice of anesthesia, especially in children around the world. So these organisms proposed guidelines which should be followed by everyone. But as people practicing both in South Africa, which is you would say it's an intermediate LMIC, and then Cameroon is a low, like South Africa, I can classify South Africa as an intermediate kind of setting, because you have the middle income setting, and then you have the low income setting within the same country, and then other countries like Cameroon, which are in the low income setting, and sort of found out that there was a mismatch between what is actually done in the setting of South Africa and in the setting of Cameroon, as well as many other African countries. Because, as you know, Cape Town Red Cross Hospital has a fellowship program which brings together local, regional fellows from different countries, Uganda, Kenya, Zambia, to sort of improve the anesthetic experience, and most especially share what they do in their countries and how it can be adapted to their context, because the anesthesia done in the UK cannot be the same as that done in Pakistan, cannot be the same as that done in Chad, for example. So back to Africa, we found out there was a WFSA Global Anesthesia Workforce Survey, which found that there was a the anesthesia, pediatric anesthesia workforce was really very much reduced compared to what was recommended by WHO and probably the GIGS initiative. And we sought to find out what were the reasons why we, in spite of having all this knowledge available on internet, available even in different university courses, what explains this difference and this disparity. And bringing it down to pediatric anesthesia, we found that the main things were the challenges that we have is the challenges of practicing pediatric anesthesia as a whole, and specifically the aspect of ventilation, because as we know, there's most procedures you would find in pediatric, in adult settings. There are some procedures which in adult settings could be done under regional techniques, but in pediatric settings, general anesthesia is like one of the things you would have to do to ensure safety for the patient, given the difficult area and all the different specificities of children. And so we sort of decided to break down these challenges into 4 main chapters, because there are quite a lot of things we have to bring them together and make it more understandable. So the first thing, obviously, is equipment. Equipment, which is a big problem, right from choice of equipment, right from procurement, and even from the basic problem of limited resources. As you see in the topic, resource, we refer to say resource constraint, because Africa isn't really limited in resources, it's more of constraint in terms of distribution of priorities, and healthcare, unfortunately, isn't yet one of those priorities. So from an equipment perspective, we brought out 4 different chapters. First of all, we had the difficulty with the essential monitors. Obviously, for general anesthesia, you would expect an ECG, you would expect oxygen saturation, end-tidal CO2, you would expect respiratory rate, and all other things on a monitor, well presented and all of that. But in the average low or middle income setting, you don't usually have all of that. And so most of the settings are sometimes reduced to using just oxygen saturation with organizations such as Lifebox, which have contributed to share out, do free donations of pulse oximeters in most of these countries. So if you happen to go around in most limited LMICs, you would realize that there are a lot of life boxes around in the hospitals, be it even in the major cities or in the peripheral areas, which have been left by the different donations done by the Lifebox Association. So most of the time, it's limited just to oxygen saturation, which from the WHO perspective is the minimum required that should at least be available. So that's from general perspective, it's difficult to come by, but where we can, this is the only item that we can have for monitoring. We all know, as we said earlier on, that pediatric anesthesia depends a lot on general anesthesia. And as such, who says general anesthesia will talk of intubation, talk of airway manipulation, and obviously the importance of end-tidal CO2, which in many settings, there are even some trainees from Cameroon who are just on the panel. I just saw them come up, and even from other countries. Many registrars go through their trainings without having to use or manipulate end-tidal CO2, which is really a big issue, which means the airway becomes a problem. What is supposed to be safe becomes a problem, because not ventilating with CO2 can be absolutely catastrophic, especially when we know what it's useful for. And also we brought out the use of adaptations in our context. Like for example, we have a lot of people using the precordial stethoscope, which many of you probably haven't heard before. Maybe it was used a long time ago, but where people place a stethoscope on the left side of the chest, which enables us to have the heart rate at the same time as the breath sounds, especially knowing that if we have a selective intubation, it will definitely be to the right side. So if we don't have anything on a precordial stethoscope, we know our tube must have moved, or there's probably an issue with ventilation. And the anesthetic nurse or the anesthetist keeps the stethoscope on all the time, keeping up with the heart rates, which can really be tedious, but which are the techniques which have been used here for quite a long time now and have saved lives, I would say. Secondly, the anesthesia machine, many settings do not have anesthesia machines that are capable of giving a proper safe ventilation for children. And as such, most centers depend on manual ventilation for quite difficult procedures. And of course, manual ventilation doesn't ensure proper pressure or volume deliverance to children, which is very important for avoiding baro and volotraumatism. So it's baro and volotrauma, which are some of the issues we find when ventilating children. One of the adaptations as well is that we tend to use most of the Jackson-Rees circuits, especially Jackson-Rees type 2 or type 3, which enable you to have a better feel of the pressure in the ventilation rather than some adapted. We have some other adapted instruments for ventilation. So probably some old non-functional anesthesia machines with bags are not adapted. Some people even do anesthesia with ambu bags, which can be really very uncomfortable and doesn't give you the precision required to ventilate children. So I spoke of the Jackson-Rees circuit. Availability of ET tubes usually falls into part of the circuit. Sometimes some centers have about 2 or 3 ET tubes of the same size for a population of about 50 to 100 children or procedures per year, which makes it quite difficult. I mean, they keep reusing the same tubes because they don't have a choice. They don't have a proper procurement department. And even intubation sometimes is difficult because they don't have appropriate size bleeds. These are some sort of the challenges that we face. Obviously, if we have issues with anesthesia machines, then, I mean, the gas supply becomes another issue. This is the last part of the equipment problem. Most centers where surgeries don't have oxygen, but getting access to medical air is a big issue. Even many major centers, it's practically impossible, or maintenance issues make it difficult to have access to air, to medical air. And as such, we find ourselves in these settings ventilating neonates or little children with 100% oxygen. We know the toxicity it has on the retina and on the lungs and all of that. And it really influences the morbidity and the mortality that we have. Also, in terms of volatiles, you would be surprised that in many settings, especially in Cameroon right now, even in major centers, we still use halothane, which many people have heard about as probably in the museum somewhere. When I went to Cape Town, it was in the museum in Cape Town, and every time there was a discussion about halothane, all the department would be like, "Hey, where's the halothane guy? Tell us about halothane." So we still are forced to use such volatiles because of lack of equipment. Nitrous oxide is very expensive and not affordable by many centers, so very few people are exposed to its use, and so they're not, like, the consumption even of the available gases are there. From a protective point of view, many of these centers, even with these gases and the toxicity that we have with some of these, we don't have a scavenging system, so it makes pollution a big issue. And sometimes in theater, you have people who get all this exposure to anesthetic gas throughout the whole careers without necessarily knowing, like, the impact of this, probably linked to the ignorance and the lack of equipment. That's from an equipment point of view. From a training point of view, it's a big problem because in Africa, we have very few programs that seek to train practitioners on the practice of anesthesia in Africa. And that's one of the things that has been taken up by the African Pediatric Fellowship Program, through which I had this fellowship that I completed in Cape Town. They are based in Cape Town, and they've sort of tried to get participants from different countries and get them learn the basic anesthesia and try to practice in their own settings. Most of the time, the few pediatric anesthetic practitioners that we had over the past years had to go over to the UK, to the US, to Australia, and obviously it's not the same setting. And when they return, they're like sort of lost. They ask for equipment and it's not available. And most of the time, these trainees don't stay back, and they probably return to the settings where they were, leaving the areas where they were as empty as they were before. So it's a question of contextualizing the training that is done for people who are to practice in Africa. And now we're moving more towards training for Africans by Africans, so that people understand what is done in our context and are able to do those things to save the lives of the children with what we have. Now, another important issue is, even when we have the proper equipment and with the challenges we have with equipment and the limited training, we have an issue with the decision-making around intubation and ventilation, because remember, general anesthesia is an important part of pediatric anesthetic practice. So you would see circumstances where the airway seems like, an example, if we're doing, if it's a kid who comes for a hernia repair, obviously you would say, we do an LMA, or we intubate, and then we probably put in a cordal and then do the procedure, because that's the standard procedure. That's what's normally done, and that's what's safe for children. But in an African setting, because you have the problem of availability of proper ET tubes, you don't have a ventilator, you probably have staff who are not comfortable with ventilating children, because probably the equipment isn't proper, and they haven't had some decent training or some proper training in the management of children. Usually these kids will be managed by adaptive techniques. Like, for example, people would give intramuscular ketamine, which will serve as sedation over a period of 20 to 30 minutes, maintaining spontaneous airway breathing, and then in that situation, either do a spinal, because the spinal is probably more easier to do than a quarter, because a quarter, to do a quarter, you need a bit of practice to probably to get the proper site. So you see the comparison between having to do a quarter and a GA with all that it entails, and just doing IM ketamine and probably a spinal or a quarter for those who have some training in that aspect. Those are some of the decisions taken. And even further, especially because this paper was trying to limit itself to the anesthetic part, the influence of the intensive care practice, the intensive care after difficult procedures, falls back on anesthesia. Because, for example, I'll take an example. I put that example in the article because it's something which was really very dear to me, the management of tracheoesophageal fistulas, which I had the opportunity to manage as a specialist my first 2-3 years before going on fellowship. It was really a very discouraging experience. I personally went in for 13 procedures and we didn't succeed with any of them because we had a serious issue with the intensive care management. So the management of the ICU, for example, if a child who comes with a fistula, you know that probably they come with the lung infections, and the management has to take into consideration the fact that these children are not probably, after a long procedure, which will be about 2 or 2.5 hours, they need some ventilation to keep them, to optimize them for better recovery. So usually in our settings, we are forced to do everything to have the children extubated before, or extubated on the theater table, or if possible, kept on the theater table till they can't breathe on their own or till they're comfortable enough, which sort of conditions the standards. Because elsewhere we'll be like, well, from theater, no stress to extubate them properly, just put on sedation IV, wheel them into the ICU, and then leave them there for 2 to 3 days with the parenteral nutrition or whatever it entails. So it sort of conditions whatever technique that we try to do in theater, which I decided to use as that example. So those were just a few examples we took with respect to the clinical decision making. There's several other examples, but just those two to illustrate. And the biggest challenge, which is the fourth one, is the data challenge, because in order to do what is adapted to our context, we need to know what is being done. And you need to know what's being done. We need people to publish what's done. And for people to publish, we need practitioners who are actually on site and who are able to consecrate time to collecting the data on the numerous cases that they handle, which unfortunately is very difficult because from a pediatric anesthetic point of view, there are very few dedicated practitioners who don't really take time off to do pediatrics. And sometimes just because of the frustrations of these cases, they tend to stay away from what is pediatric and choose what is more comfortable doing those cases just because, well, it's convenient and it's an emergency. I probably have to do that, which influences the quality of the data collected and even the quantity also of data that we have on pediatric care, because there's a lot of surgery being done, there's a lot of anesthesia being done in children, but there isn't enough data being reported to sort of push in the sense that some work is being done. There is the African Preoperative Outcomes Research Group, which has been working very hard to get a lot of data in children in the pediatric anesthesia. And currently there's an ongoing study, the ASOS PED study, which there was the ASOS study which was done in adults, which came up with the famous conclusion that surgery, when you're doing surgery in Africa, you have a 50% chance of not making it compared to someone in a high-income country when you consider Africa. And so currently the pediatric phase is being carried out, and I'm glad to say I'm part of the panel working on collecting on the data in Cameroon, which is quite difficult, but we're trying to get as much data as possible so as to bring out these elements that would help boost the findings from the findings from our little article and help to make the practice of pediatric anesthesia in Africa a bit more interesting and a bit more safe for the children that we manage on a daily basis. Thank you.
Wonderful. Thank you so much for a very nice summary of your paper with the collaboration of Faye and Rebecca, or Dr. Evans and Dr. Gray. So I'm going to open it up to the floor if anyone has any major questions. But for those who joined in late, so basically we're GASOC, this is a Journal Club for Anaesthesia, which we run every 2 months with a different theme. The gentleman that kindly spoken just now is one of the authors of the paper that's been sent to you, Dr. Ndikontar. I'm trying my best. What he's mentioned is basically the journey of writing this paper and then the summary of the paper, of which I can summarize very quickly. So he went to Red Cross and had a fair amount of frustration about, a good frustration about the different mortality and outcomes in low middle income countries compared to even in intermediate middle income countries, if we can't count South Africa as such. Therefore, he wrote this paper on 4 major areas about the challenges, such like equipment, things like how he had those lovely photos of putting a precordial stethoscope on, such like training. We talked about a very few program that is in Africa for Africa, where the Cape Town program came in quite useful. Then we talked about difficulty in intubation and ventilation. Even if you can intubate and succeed in, say, for what we talked about, a TOF patient, transesophageal fistula, then you need to stay with them until they're extubated because there's no such facility of keeping them ventilated. And then we talked about a data challenge, which is quite hopeful actually, where Raymond, if I'm allowed to call you Raymond, is the Cameroon data coordinator for the pediatric setting about the ASOS Peats, I think. Let me just double check my notes. And that's really fun. So we had a few comments which I can tell you about. So first, Rachel was like, "Hello, thing, wonderful. Is one of the best things for difficult airways." So someone resonating with you there. And then let me just open up the chat box really quickly. Helen asks about barotrauma. Do you think barotrauma is something which is more common in PEETS cases due to less complex equipment in your experience, or you think there are any other local techniques that could help you avoid it? Are there any non-anaesthetists in the room? We can explain what barotrauma is first, and then we go into it. You don't have to raise your hand, maybe give me a DM. But basically, we talk about boiler trauma and barotrauma in anesthetic ventilation. Barotrauma is too much pressure and causing major, so in terms of causing trauma, and volume trauma is too much volume, causing trauma in the small alveoli. The concern that we have for children is they are very immature and they have different, and they're very prone to collapsing. And correct me if I'm wrong. I finished the FRCA 6 months ago. I think I've given them all back to my examiner. But that's my one-liner summary for that. So yeah, back to you, Raymond. Do you think it's an equipment issue, or do you think there are other techniques that could, mitigate the risk or minimize the risk? Is what I'll be asking, which is what I think Helen is asking.
Yeah, it's a difficult question to answer because sort of the only way to know if you cause barotrauma is to be able to measure the pressure in the airways, which most of the time in most settings, the available anesthetic machines do not have that measurement, which even if they were ventilating, if it was an anesthetic machine, probably very few would have. And even where it's not, and then there's manual ventilation, you can't actually judge the pressure, especially because the neonatal, for example, I always like taking that example. The neonatal lungs are really very, very fragile, and probably we may think we are being as soft as possible, but I mean, your arm remains your arm. The pressure you exert in your arm, like imagine doing this for the next 1 hour, 2 hours. At some point, you're probably not giving enough pressure or enough volume, and the next minute you're giving something which is harder. So it's a difficult question to answer in terms of what solutions there are. The only solutions that there are is to get a ventilator, which it enables you to measure that pressure. Or in a circumstance where you really can't have one, you should give a priority to spontaneous ventilation where possible. That's why we tend to choose techniques where the patient maintains their own spontaneous ventilation, which sort of saves us from getting to the point where we need to give an extra volume or extra pressure, especially given that who talks of barotrauma with all the high volume and pressure should also talk on the other side of insufficient volume and pressure. We have atelectasis, which is sometimes difficult to catch up after, because you need a proper anesthetic machine to do recruitment
maneuvers. Yeah.
Which, I mean, in doing those procedures, if you're saying, okay, look, I want to do recruitment with your arm, it's very, very inefficient and could be more harmful. So where possible, get an anesthetic machine. If not, you should give priority to spontaneous ventilation.
We did that too here. I when I moved from adults to peds, I was not comfortable with just like the bag's moving on its own. This is not fair, but we will learn to cope. But yeah, so that was even in quaternary centers in Great Ormond Streets and stuff. They're like, yeah, just leave the child to breathe on their own. If this end tidal goes up to 7, don't worry. Just them breathing, and that's that. Obviously, I do understand you don't have the luxury of end tidal, but I did like your contraption of making an end tidal. Somewhere, if we refer to the figure 2, is that always the case that you guys put a needle in and then put whatever side stream analyzer that you can find in?
No, that was just because there are several types of, normally people would tend to ventilate with the large adult filters, because the pediatric filters are not also available. That's an equipment problem as well. And then they like put the side stream ports after which gives you a lot of dead space.
Yeah.
Even the filter itself has a lot of dead space.
Yeah, but adult filter on a child, like that's not.
You sort of have a lot of dead space, and your entire CO2 is really not very efficient. And so one of the techniques I adapted is to like put them on a tiny needle, a brown needle, and then insert into the tube, which gives you like the slightest volumes. We're talking about close to, sometimes for needles about 1.5 kg, you're talking about 8 mils tidal volume. So the least tidal volume that comes out, you can pick up some CO2 in that way rather than getting in at the end, because we have the issue of the filters and the adapted ports, and especially the inline end-tidal CO2 monitors are probably too heavy sometimes, and they're
too bulky.
Like pull out the tube. So that's sort of a way in which, when you're really limited and you can have an end-tidal CO2 monitor, that's a more practical way of doing it, which is being used by a lot of people in limited settings who can't probably have filters or the entire CO2. They sort of adapt it that way. Just a quick comment on halothane. It's a volatile I've used for a long time, and I am trying to cut away to break off, to have a divorce with halothane, because sometimes when you get used to bad habits, it becomes a good thing. It may be good for a tricky airway, but I bet you when you use it for a 2-hour procedure, you almost always get an arrest at about 30-40 minutes into the procedure, because it like sort of completely gives you a myocardial depression, and you sort of see your heart rate drop. And at that point, you don't know whether it's your hypoxia or whatever at some point. For short induction before switching to ISO, it's a good idea, but maintaining it for over 30 minutes is I would say, for over 5-10 minutes is a very bad idea.
So we've got, that's wonderful. I like that. I have never used halothane, but the only time I ever used halothane is when I came to Uganda and basically went on a developing country anesthesia course, and what was put there on that over a drawer of a vaporizer was halothane. I was like, need to think about my primary knowledge again and see what we're going to do about this. So we have got questions from Pakistan. So so basically they were on the same theme of the interesting, innovative ideas. So are there any other locally sourced solutions to the problems that you mentioned? I suppose she's talking about putting the Latin side stream and tidal monitor onto the tube. So she says, yeah, so she was like, are there any other of those innovative ideas, and what is the popularity of these ideas amongst your doctors?
Okay. In terms of popularity of most of these locally sourced ideas, I think the most popular would be the precordial stethoscope, which I grew up as a medical student here in Cameroon to see. That was the first, like, it's sort of the gospel truth in pediatric anesthesia. When you have a child in anesthesia, be it a regional technique, be it spinal, be it general anesthesia, you must have a precordial stethoscope. And even sometimes it was used in adults, in adult anesthesia, to sort of have a constant awareness from the anesthetist, in addition to other simple techniques such as constant palpation of the radial pulse, knowing that if you start feeling it a bit thready or weak, you have issues with your patient's volume. So I think that's, for me, that's one of the most widespread techniques which you would get from almost everyone. One thing I left out was, before this study, there's a small African pediatric anesthesia community where sort of when we have issues, we throw them out and like, who does what. So most of these ideas were also gotten from these people who like gave their little experience through short interviews, and then we like brought that together with our experience. And obviously we had a very big Pan-African community in Cape Town, people from Zambia and other places, Kenya, who sort of gave in their experience on these things. So the precordial stethoscope would be the first, which I would consider like really the most important. The use of the Jackson-Rees circuit, which sometimes is used just for induction, but maintaining it throughout the whole procedure, because it allows you to sort of somehow control the pressure you have. It's because it has some sort of a valve which some lets off after 40 centimeters of water, which could be one of the solutions to the barotraumatism, as one of the questions asked before, because it's sort of open-ended on one end, and sort of when you see it increasing up, you know, oh, I should be close to 40, so you release a little bit. And it gives you a better feel of the ventilation, because it has quite a small lumen, and so doesn't allow any major pressure differences from the patient's airway to the back. So they used many centers where they probably have issues with the ventilators that don't do pediatric volumes, or that don't actually ventilate automatically on their own. Many people use the Jackson-Rees circuit, and which is the Mapleson B or C, one of them, whichever is available, to sort of go up with ventilators. So I'll put those three: the inline end-tidal CO2 monitor with the needle in the tube, the precordial stethoscope, and the use of the Mapleson circuit for long procedures as well.
That's wonderful. We have someone from Kenya joining and just really enjoying this as well. The Sriya, as far as I remember, she is in Scotland and was basically really enjoying the discussion about the major challenges and importance of contextualizing training, such that you're Africans training in Africa by Africans. Mm-hmm. But I suppose there might be an aspiration of working in Africa there. So therefore, she was saying very broadly, what would be the underlying principles and basics for trainees to get to grips to be able to be successful in an LMIC setting? I'm going to expand and take the liberty to expand, because I'm the host, not only for training, but also for attitudes. What do you think are the major principles that you think, if someone wants to, I don't know, come and work in Cameroon for a while or work in South Africa for a while, like, what do you think are the major underlying principles that they need to get to grips of, basically?
Yeah, very, very interesting question, because those are some of the ideas we're trying to put up to keep Cameroonians here, because it's not just of having people from outside coming in, but the issue of having people trained here to be able to stay and do something here. It's difficult keeping people. Just to paint a picture of the sad side of the story is, for a country like Cameroon with about 27 million inhabitants, we have just a total of 48 physician anesthetists. And if I count the registrars in training, it takes us to about 65 or 68 in total. So it's a big problem, and it's not just people out there selling anesthesia to people out there, but selling anesthesia to people here in Cameroon, so that those trained here actually learn to stay here. I think those sets necessary, because we're in a limited, we're in the resource constrained settings, and that's one of the things we need to accept. It's not going to change anytime soon. It will take a bit of time for development, for policy and all of that, but accepting that that's the context in which we are, and somehow being able to lower our expectations without necessarily dropping the standards of care. Very difficult to imagine, like, look, I shouldn't expect to have this, but I should try to maintain a minimum. So getting that compromise with the equipment that we have. And that can only be possible when we have skills in advocacy, and which is one of the important parts, like being not just the anesthetist who comes in, clocks in at 9 or at 7:30 a.m., finishes his list, and then probably helps with an emergency list, and it's gone by 5, and then back on the next time they have to work. It's different. Like here, it's being interested in what happens before that patient arrives, being part of the team that discusses the plan for this patient, and being available to intervene in whatever happens after. It's being part, learning how to be part of a team and how to be part of someone who intervenes, even to the point of from a public health perspective. Like, for example, if the cases of fistulas that we have, we know that the children who have esophageal fistulas arrive late, and because they arrive late, they have the challenge, they clearly have aspiration, because probably diagnosis is going to be late, and because of the aspiration, they have pneumonia. And as such, if a child comes on the 5th day, the probability of them having severe pneumonia is increased. But what if we could not just be in the OR waiting for these children to come, but going out and being part of a team which brings together pediatricians, brings together pediatric surgeons, brings together obstetricians, and like, look, when you do your ultrasound, your trimester ultrasound, if there is an issue that makes us believe probably there's a hydramnios, which makes us think there may be an issue. Maybe there is no communication between both ends of the esophagus. Then instead of just following up the child, send the child to a center where the appropriate care can be managed, so that when this child is born, from the moment the child is out of the womb, we can now intervene in a better way, rather than just being the anesthetist who receives the patient at the door and then like at the end just hands over the patient to the ICU. So that those are the kind of skills you would need to develop. Being part of a team, being part of having a broader perspective on the cases we meet, having a perspective on where's this patient coming from, how can we make this patient's arrival better, and explaining to those who intervene before the importance of having them in the hospital earlier, and preparing these patients for the post-operative care, because you won't do anesthesia. Okay, where does this patient go? What bed is available? What analgesic technique is available? I think those are the main skills that working in a setting like ours would be required. And obviously, as my special bonus, I always like to add is having excellent ultrasound skills, because we're in a setting where we need point of care ultrasound skills, especially for analgesic blocks, because these are actually techniques that help us avoid heavy sedation with morphine, with fentanyl, bidaz, ketamine, which would be very complicated because they may not be available. You may start with ketamine and probably the family can't afford to continue with it, or with bidaz or with morphine, and the family can't afford. What do? You need to be able to do other techniques which make the children comfortable and which are more expensive. So being, as a summary, having a broad perspective on what happens before and after, reducing your expectations and without necessarily dropping the standards of care. That's finding a compromise between those two. Having an economic approach to the anesthesia you do, and also having proper pain management skills with cheaper options for these children. I think that's the package you should have if you really want to work here, which is a great experience after all. That's why I'm still here.
You're coming to my next question, but I suppose that there are a few things that actually that came along. So first, actually, it resonates. I think anyone, even working in high income country, if they have a better context of the global patient experience, I think they would sit a good stead in being good candidates, say for registrar training or say for consultant training. That's been quite drilled into our training. I have a few questions, hopeful questions and hypothetical questions, just because I'm that kind of person. So you've talked about a fair amount of resource constraints. What can we do in high income countries to help? Because after all, GASOC is about collaboration. We've heard a lot about the constraints. Are there anything that you can think of that we can help? I don't know, maybe, do a seminar in some sort of research situation if you guys don't have time to do it. But like, I'm not saying we are better. I'm saying, are there anything we can do to help? It's basically a very open.
I think going back to the 4 pillars of the article, which were equipment, training, probably decision-making and data challenge. I think those are the main places where being in a high income country, you can still help to change a lot of things. From an equipment perspective, there is a lot of, and I've had this because I'm more into a situation of advocacy, like pushing for more for people here, because the term resource constrained really brings up, because when we say resource limited, African countries aren't that poor. It's just the distribution of resources and the priorities which are a problem, and it will take a lot of education and a lot of advocacy to bring out these, to sort of level the odds in this. And so from an equipment, I'm pushing for equipment to be made available, and for that equipment to be made available, it's sort of, you have lots of equipment which probably is past the period when we would say they are no longer necessary. For example, I'd see most of the anesthetic machines we have in our hospitals are not brand new. They're brought up over, like, okay, look, someone says we've used it for 5 years, it's time to switch to the new one. The brand wants to move to the new one, so we're getting a new one. Probably helping out with this equipment, not in the sense of, okay, this is bad, this isn't working anymore, let's send it to there, but helping out with equipment when they can. But I think that's sort of makes us lazy on this part, because the idea is to have a sustainable solution to the problem. So I wouldn't say that is a proper solution. It's not a long-term solution. It's probably like they help sort out for 6 months or a year, because eventually after that, maintenance is a problem, and you have a machine which is no longer effective and efficient, and people are like, yeah, well, it came from there, so it should be. So from an equipment point of view, not really. I think training is also a very important aspect, because from a training point of view, there are lots, the exposure to training, and that's why I really appreciate this forum, the GASOC forum, because it sort of brings together people from different settings, and there's that exchange. The exchange in terms of like things like these, to make people know this is what happens in this country, this is what happens here, and we know the differences, and we learn about what happens elsewhere. For example, you'll be surprised how many registrars in African settings don't really see the importance, or they've gotten so used to not using end-tidal CO2 that they don't really see why they should push for it. And that is becoming a problem. There are a lot of little things that hang around. Some people don't have access to EKG during anesthesia, so they're like, well, we have the heart rate, so why? Not knowing that there are a lot of things you can get just from the ECG. So those are the things that's a very important. And for me, that's the most important way. Like, it's emancipating people on, look, you don't have access to this, but this is important. You as a registrar today, in 4 or 5 years, you're going to be one of the people making the decisions, especially in a country with less than 50 physician anesthetists. So through training, you actually open their eyes and make them realize that this is important. This is important here now, and in what way can you apply that? And it's that exchange that makes people to know what difficulties to overcome. And this will obviously fall down to the clinical decision making, because in the same way as we want to adapt what we're doing to our context, but still remain like following the canons of anesthesia, we should also remember that the more you get educated, the more you know about the importance of certain elements, the more you get scared of not doing the things that are prescribed. And so the more you get educated, the more your standards go up, and you're like, nah, we shouldn't be doing this. We shouldn't be doing this. Just like myself, before the fellowship and after, like when I come back and I see people like filling up the vaporizer with halogen, I'm like, yeah, maybe not, probably IV induction and then ISO, but not halogen, just because I have been in a context where I've seen the big difference in the quality of care when it's not used. And obviously, because there's training and exchange, there will be an impulsion to carry out research. Like, yes, what are the statistics? What do we do locally? And it's only when we know what happens here, and the problems we have, that we can address them. So I think that's one of the ways that it can be done. It comes like it's a helping hand, but it's sort of a push to pull people up and for them to push their advocacy, because the real solutions come from within. Because that's only where the solutions can come from. The real sustainable solutions can only come from within.
Wonderful. Afsan also talked about this, which I also really enjoy, is talking about the systems. I've worked in South Africa with the local government. It's not one of the most pleasant experiences I've actually had before in my life in terms of advocacy, but it does show in terms of once you start engaging the platform and advocate well and get the right stakeholders on your side, then actually things can actually move a lot quicker in the most appropriate way. I have a few quick questions. One quick question actually for you. You talked about you being the major lead in Cameroon for the ASOS PEATS data, which is very important. However, how do you engage people to participate? Are you a carrot person, or you're a stick person, or you're a bit of charm person? What's your kind of nudging method, is basically what I'm trying to say.
So that's it's quite a big study, and I admit to you, we're really struggling with getting people on board. So it's a combination of all of that. It depends on what I have in front of me. Like, if I'm like, well, this is a bit of a difficult one, I'd probably circle around like a little happy puppy, like, hey, I'm here again. It's me and my study. But it's more basing. I try to get more on the aspect of, bringing people to realize the importance of the study. That's why each of the hospitals where we try to get people involved is we get people who are involved in pediatric surgery and anesthesia, because these are the people who will intervene. And obviously telling them, look, this is what was found in the ASOS adult study, which made us realize we are really not we're not really getting the desired results. We're lagging. And if this is what's happening in adults, then what about children, where people are not really interested most of the time, or not really interested, but people are mostly scared and wary about, no, what if it doesn't work out? So it's more bringing people to realize this. And one of the platforms that really helped me reach out to these different centers was the fact that while even in during the fellowship time in Cape Town, I sort of created a group, bringing together, during training, we worked with ped surgeons, we worked with other anesthetists, we worked with obstetricians, and sort of brought them together and said, look, what if we, stick together and we discuss the difficulties we have? Like, if we have difficult cases, if you have this, how can we handle them? And so on my return, after training, all of them dispersed around the country. It was easy, like laying hands on these people to use them as support to carry out the study, which is still very difficult. I mean, we're still lagging behind in Cameroon a lot because it's not easy trying to bring out. It's quite a pediatric anesthesia is quite a very, I would say, a very young specialty in Cameroon on its own. So, imposing that on people may take quite some time. So we're struggling, but we will get there.
I'm sure you will. I'm sure you will. Will you want to say something, Jean?
I have a question.
Yeah, go ahead.
It's quite a big question, Raymond, but thank you so much for your talk so far. It's been incredibly insightful, nuanced, and just really amazing work that you're doing. My question to you is, how do you, in maybe district hospitals or smaller hospitals where there isn't a post-operative care setting, because that is so important, like you say, if you're doing big surgery, if you're doing important surgery, if you're doing surgery for sick patients, and you are on a daily basis, how do you foresee the setting up of a post-operative care unit, either HDU or ICU setting? Because the challenges are huge. I've worked in a hospital in Zambia before, where a lot of the senior surgeons were saying to us that, oh, we need an ICU, we need an ICU. But in terms of, the delivery of oxygen to the wards, in terms of the disposable equipment, we were running out of NG tubes, we were running out of catheters, sometimes running out of cannulas. And, in terms of investigations as well, we often ran out of reagents to test for creatinine, to test for urea, etc., etc., etc. It's a huge multitude of challenges. But from your point of view, where do you see this going? Where do we start?
Very, very, very difficult. Very difficult situation, because to start up with, to set up an ICU in a district setting, for example, like in Cameroon, it would be a really very big challenge, because you would first need to get the people to work in those settings, first of all, and people who know what it entails to work in an ICU. It's a very broad question to answer, and even in the major cities like Yaoundé, where I'm managing an ICU, is still very difficult, because as you've stated, the problems there are obvious: access to oxygen, probably to medical air, to like consumables, which, I mean, you keep using, changing up and down. And sometimes, because the costs rest on the patients, we don't yet have some sort of universal health insurance system in Cameroon, although the government is working on it, but it's taking quite some time to set it up. It's not going to be that easy. So I think the first step, in order to ensure that we have something, ensure that we have the means to do that, is to start by getting universal health insurance in settings like Cameroon, because even in areas where, like in the major cities where you have the hospitals which have some ICUs which are quite performant, you have that blockage where you have a patient, this patient we need to change the CVP, we need to put in another one, and the family is like, no, we just can't afford. And these families, there's some people who've probably sold their land, they probably mortgage all of their properties, and they're like, look, we have nothing else like that. At that point, you're sort of a sad practitioner, because you know what you need to do, you know what the patient needs, but then these two don't meet. You can't give what the patient needs. So I think that's the first point. When we get to the point where there is a system where everyone has at least a percentage of their healthcare costs covered, then we can start dreaming of setting up proper ICUs. And then at that point, we can now get people who are trained and who know what it entails working in an ICU, actually guiding the supplies and everything. But for now, it's a very big challenge. And most of the time, we just stick to trying as much as possible to work on prevention and getting people to actually detect these pathologies earlier as possible, and then sending them to the centers where they can be managed. And obviously doesn't solve the problem of finances, which sort of cripples the whole system.
Fantastic answer. Thank you so much.
Yeah, we are not resource free, but during COVID we had to set up an ITU in 3 weeks, and that was not an easy task either. You may have the resource, but allocating them, prioritizing them, getting the right people at the right place on a finite pool, that's equally challenging as well. Cool. Sorry, I haven't seen any more questions. However, I'm promising this is going to be the last one. This is a very quick question. Genuinely very quick. Someone was writing in the survey to ask questions beforehand, and I'm trying to interpret whether this is their question. They said about postponement during an upper respiratory tract infection. So does that exist in African countries in terms of you postpone? Because this is in the exam, you know what you're going to answer. If they are in a developed country world, if they have a temperature, high heart rate, not really themselves, you're probably going to postpone an elective surgery. And if it's urgent surgery, you just need to grit and bear, just need to go and do what you can do and hope they have the best post-op care and plan for that. But what about in low middle income country? It goes back to one of those questions earlier. It's like, is guidelines and clinical practice a fair amount of discrepancy, and what happens in, say, Cameroon probably won't be similar to what happens in Cape Town, having been to Cape Town, but what happens basically is my question.
The standards are the same, like the basic principles are the same. The child comes in, upper respiratory tract infections, you know what you're exposing yourself to, and obviously in a setting where you may not have the means to manage bronchospasm as efficiently as in another setting, you'll be like, nah, I don't want to engage. Although the solutions are actually not that different, they're not that very difficult, probably just because, I mean, we're not very comfortable with this, so we'd better not try it. But that's what you would find in the major cities like in Yaoundé, in Douala, in Bafoussam, where you have anesthetists who sort of categorical, and you also have patients who probably drive to the hospital or take a taxi to the hospital or even come in an ambulance. But when you go into the district setting, where most of the time you have sort of outreach programs, which some of us have been doing, even as a medical student, going out to these far areas and then seeing these children with hernias and all the procedures which would normally do on a daycare, on an ambulatory basis then on a day surgery basis in town. And the issue there is, I mean, you're here for just 2 days. You have this kid who comes with the large hernia and undescended testes, and you know the next time anyone's going to come here is probably in the next 4 or 5 years. What do you do at that point? Do you sort of tell them, oh well, he has a cold, so no, we're not doing it. Bye, go home, come back in 3 weeks. You won't be there in 3 weeks, and this child may not have to surgery after all. So at that point, it's sort of weighing the pros and the cons. Do we let this child go home, especially knowing that if we send them home, they will never return, not because they don't want to return, but because they can't return, they don't have the means to return. So it's when you go to the remote areas, which constitute almost, I would say, 80% of the population, in these kinds of areas where you don't have that access to that care. So it becomes tricky, and at that point you start weighing the pros and the cons and saying, look, we'll go in here and we'll do what we can and see what results we have. So that's sort of how it's managed here.
That's a really nice answer. Thank you very much. For those who don't know, Ryan's joined. He's our VP Vice President in GASOC. However, if you guys don't mind, I'll probably start wrapping up because I can't see any more questions coming along. So before I wrap up, thank you very much, Raymond, for being here. I look forward to seeing you in our future journal club if you can tune in. Which brings me to say our next journal club is going to be on the 24th of September. It'll be surgical focus. And if you want to keep it in your diary, it's 4 p.m. BST time. And the next one for anesthetics, if you're very keen and you're trying to get some authors to come as well, that's my job. It's on the 28th of January. So in the brand new 2023. So, and that's yours truly's birthday. And I will turn up, despite being my birthday if I'm not on call. So that's one thing. And for closer events, actually, we have our GASOC conference finally in person. And for those who can't come, there's also a hybrid option. So 22nd and the 23rd of October, we've got some really prominent speakers coming. And the theme is about sustainable global surgery. And not only are we talking about the green sustainability, we're also talking about infrastructure sustainability, which Raymond, you alluded to earlier, which conveniently is very important to maintain. There are abstract deadlines coming on. So Raymond, if you have trainees that want to give in some abstracts on global anesthesia, global surgery, global obstetrics, deadline is on the 2nd of August, next Tuesday. So make sure you get it in ASAP. And there's an essay deadline. It's talking about how the difficulties and challenges for pre-hospital care, because with the essay, there's a cash prize in British pounds, as well as gives people a chance to go on the Friends of Nepal ambulance. I don't think they cover the travel, but they will give you a ride. Pardon the pun. And the essay deadline is on the 2nd of September. So those are great things. Plug it to all your friends and family. And if I can see you in person in Sheffield, that'd be amazing. If not, I see you virtually. Thank you, everyone. It's been an amazing experience. And thank you so much for plugging in from over here. And thank you again, Raymond, for being amazing. And thank you amazingly, Paige, for being here. Thank you. Take care. Bye.
Bye, everyone. Thank you. Thank you, Raymond.
Take care. Bye.
Bye.